So the special senses include smell, taste, sight, hearing, and then your equilibrium, which is very important. And if you remember, these special senses are also tied into where the cranial nerves are. And specifically, smell is the olfactory nerve, cranial nerve number 1. Taste, remember, ties in a few other cranial nerves. So you're looking at the trigeminal nerve, the facial nerve, and glossopharyngeal nerve. And then your vision, obviously, is the optic nerve. And then hearing and equilibrium is your vestibulocochlear nerve. So I'll remind you of those as we go through this. And then we're going to have a lot of very important receptors, obviously, with this in terms of how they're going to function. So we're going to start with the eye and vision. And when you go through and if you read the chapter, you'll see that there's a lot more contained in there. I tried to pull out the things that are going to be actually a little bit more relevant to what you're going to be doing as a medic and what you would see based on, patients and stuff. So we'll get into the eyes themselves, and this is a big old eye, obviously. And so what you're looking at is a close-up view, and the eyelashes and the eyebrows, they're called protective hairs because they keep things out of your eyes because our eyes are very sensitive, and as you know, that when they dry up, they can get very, very irritated. So they have tears that are going to be secreted, and they're actually secreted from a gland up here called the lacrimal gland, and then we have a little opening right here that actually helps that fluid actually leak, and it goes down into the nose. The white of the eyes are called the sclera, and then as you know, we have a upper and a lower eyelid. And then we have the color of our eye, which is the iris, and then the pupil itself. This is what dilates and constricts depending on how much light needs to come in into the actual eye. So the conjunctiva, this is a membrane that's very important that lines the eyelids and also part of the eyeball. And why this matters is that it's a mucosal type membrane that works with the lubrication of the tears to help maintain the moisture of the eye. And so when you get conjunctivitis, what that means is that you have an inflammation of the conjunctiva membrane, and you guys pretty much know it as pink eye. And so this obviously can get cleared up. It's a viral condition and very contagious, but it does go away, and it should not cause blindness. This is the image where you can see the lacrimal gland and where the secretory ducts are located that then fill in and then come in from the superior portion of the eye down at an angle and then enter the little tube here that then helps drain that fluid down into the nose. So this is also why sometimes when people actually cry that you will see a lot of running of the nose and a lot of what looks like boogers, but it's tears and obviously mucus that comes out. Then the muscles of the eye, these are actually skeletal muscles, but they happen to be innervated by cranial nerves. So starting with number 3, so you'll see that the oculomotor nerve that also controls dilation and constriction also controls the eyes, the muscles called the medial rectus, superior rectus, inferior rectus, and the inferior oblique. And so when you look at these, where you see these little Roman numerals, this is telling you which cranial nerve controls what. Then the trochlear nerve is going to control the lateral rectus muscle, and then the abducens nerve, number 6, controls the lateral rectus, and the superior oblique muscle is actually controlled by the trochlear nerve. And so what it does, lateral rectus obviously moves it laterally, so this is going to be your abducens. The medial rectus is controlled by the oculomotor. This is going to move the eye medially. And then the superior, inferior, and inferior oblique muscle are controlled by the oculomotor that help you elevate the eye and then turn it in medially. So like when you roll your eyes and you look up, or then if you depress your eye and turn it medially, so now you're looking in towards your nose, so you're converging, and then elevating and looking up at an angle, that would be the inferior oblique. And then your superior oblique is the one that's going to actually depress the eye, so it makes you look down and then at an angle laterally. Then the layers of our eye, so we have our eyeball, and then we have a lens, and the lens is actually going to separate the anterior portion from the posterior portion. And then we have sublayers that are called fibrous, which are going to be mostly connective tissue, vascular, which has a very good blood supply, and then the sensory portion, this is where the retina is located, and we have bipolar neurons that are there. Then the fluids that actually fill the interior of our eye are called humors. So it's called a vitreous humor. And then the lens again will separate anterior to posterior. So when you look at the actual eye, and this is an actual eyeball, this is the diagram of it blown up. Here is the lens, and the lens is going to separate, again, the anterior portion from the posterior portion. So in the anterior portion, your lens obviously is the thing that's going to help you be able to focus when you're looking far away or when you're looking up close. And you'll notice that the lens itself has these little connectors that you'll see here on the edge, and these are called the ciliary body, and then these little ciliary zonules. And these little ciliary bodies are actually muscles that help flatten the lens so you can see far away, and when they relax, they actually help the lens be more pointy so that you can focus in. Then we have a membrane, the cornea, which is going to be in this piece, the outer portion, and then our iris is going to be right in this area, that's the colored area. And then we have this little aqueous humor that's in a little bit of the anterior segment. We'll talk a little bit more how that pertains to glaucoma. And then we have the scleral portion, obviously, which is going to be the white of the eyes. Then posteriorly, you're going to have the actual retina, which is this portion here, that then feeds in directly into where the optic nerve is located. And then running through that medial portion, this is also where the vessels are coming in. And then this piece here forms what we call the optic disc, which is where the optic nerve comes in the posterior part of the eyeball. So then surrounding the sclera, the white of the eyes actually surrounds the entire eyeball, except that anterior portion where you have the cornea, which is going to be that translucent membrane. So that's pretty much what your eye is made up of. And then when you zoom in on the retina, this is kind of what it looks like. I'll go through these details of what they each do, but then this is the posterior portion that feeds into where the optic nerve is. So when you look at your retina, and every time I see this, I think of SpongeBob Under the Sea, just because of the little characters that are there. So here's, Patrick the squid, and then you've got your little pointy yellow dudes. But these guys right here, so these are going to be cells that have pigmentation. And what's important about that is that they help basically scatter the light so that you don't have like the super bright light coming in and just blinding you. So the pigmentation that's in these cells actually helps with that. What you have are called rods, which are these little purple dudes, and then you have cones, which look like little cone heads. And why these matter is that they have to do with how well you're going to be able to see. You'll see that the rods and the cones are directly connected to these little guys that look like the squids. And these are the bipolar neurons that then connect to what are called ganglion cells that then transfer what you're receiving into the actual optic nerve. And so the retina is what actually allows you to see. So when you have a detached retina, the reason why you'll have little spots that have little blind areas, or you'll see like little, white spots, has to do with basically injury that is taking place. And so when you start seeing regions where you can't actually see something where it looks like black or you're not able to focus in, that is basically when you have a detached retina. And what they have to do is they have to go in and they actually have to anchor it back on. So you don't want that to happen. So this is a zoomed in view of what you see here with the retina, and then obviously the light comes in and then hits the retina. What the rods do is that this is going to be your darker tones of light, gray tones, dark tones, and also what allows you to have peripheral vision. So rods are very important in terms of that. So what allows you to see when you have more darker conditions, what it does is that it causes these rods to become more active, and the cones are actually inhibited. What the cones do is that primarily what they're looking at is color vision, and you're looking at blues, greens, and then these kind of yellowy red pigmentations. And so what happens is that the spectrum of the visible light is what the cones are actually going to allow you to see. And so when somebody is colorblind, it has to do with the degree of activation of the cones, because some of these cones, if they're not able to very well be able to distinguish between colors that are more bluish, darker, purple in nature, that usually means that those cones aren't as active. So you're looking at what happens within the wavelengths of what's taking place with these light rays that are actually coming in. So just remember that the cones are for actual color. Then when you look at the cones themselves, you're going to be actually aiming into this region that's called the fovea centralis. And this right here, this is basically the spot where your vision is going to be at its sharpest. So this is why when there's light, you can actually see better, and it's a much sharper vision because of this fovea centralis and how it ends up being able to focus and sharpen up the actual image that you're seeing. And then this right here is where that optic disc is located. The lens itself is very flexible, and again, the way that it's able to function is because of the adjustment that these little smooth muscles, the ciliary bodies, can do with the little zonules that are the little ligaments that they're attached to. And as you age, what happens is that these little muscles actually get weaker, they get lazier, and they're not able to focus as well. So that is why as you get older, you tend to have a little bit harder problem with being able to see close up or far away, depending on what it is that is happening. So on the anterior aspect of the eye, you're going to have what's called the aqueous humor, and then posteriorly you have the vitreous humor. And it's this aqueous humor that in some cases can actually cause the problems with glaucoma. So one of the things that you're going to be learning is that certain medications will be relative contraindications for people that have glaucoma. So basically what happens with what we call open angle or open wide angle glaucoma is that you have an issue with the fluid that is supposed to come in and then drain down into that space. So what happens is the little drainage canal ends up being blocked, and then the fluid starts to build up anteriorly, and then that creates pressure and pushes back. And so when you create that pressure here, what you're doing is now you're putting pressure on the eye, on the lens, and then that pressure is now exerted on the retina, and it causes significant pain, and it eventually can actually lead to blindness. So this is that open angle glaucoma that can occur. And this is what tends to happen over time. The closed angle glaucoma, this is an acute emergency, right? So if you get on a call that suddenly somebody complains that, all of a sudden I just couldn't see anything, it's very possible that what is happening is that they have a closed angle glaucoma. And what is happening here now is now that iris is displacing again towards the cornea and blocking the exit of the fluid. And this is a sudden thing that tends to happen because of an inflammatory response, and it actually tends to occur more in Asian populations. And I don't know why, but that is basically what ends up happening. So the closed angle glaucoma tends to be a more acute, sudden thing that happens rather than the open wide angle glaucoma that takes a period of time to occur. Then the macula. The macula is the portion of your retina where you have clear vision that then will tie into that fovea centralis. And so what ends up happening is this area here ends up being affected and then starting to have problems. So what you start seeing here, see this kind of like change in the pigmentation that starts to occur? What happens is a person would normally be able to see nice and clear like what you see in the image here of these two kids. And then what occurs is that portion where the sharpness, the focusing in on the image, in the middle starts to get blurry or blinded, and it gets fuzzy, and then it continues to get worse over time to where eventually you end up having like this black blind spot. So this is what that macula degeneration ends up looking like. So it starts to occur more in the central portion of the eye. Then how we see has to do with the light bending, so that's called refraction. And the best example I can give you of this is if you have a pool and you put the pool pole in to actually clean or sweep the edges or whatever, you'll notice that it looks like as you come into the pool at the surface of the water, it actually looks like it bent the pole. That is refraction. And so what does this is the actual membrane, the cornea, that works with the lens to then be able to direct the light rays that are coming in towards the back to where the retina is located. So what you call 20/20 vision is when someone can see perfectly and they're reading the letters on an eye chart from 20 feet away. What our eye has to do is it has to accommodate the lens to see images that are further away or images that are going to be closer. So when accommodation happens, accommodation means that now the lens is actually going to become more pointy and actually be able to move in and zoom in and get closer on the objects. So these are going to be those that are less than 20 feet away. And then when something is further away, obviously it's going to be more of a distance thing. So when you're looking at a light, light waves coming in from a near source to focus in, this is what I mean by you're going to have more bending of the actual lens as it is able to make that focusing of those light rays into the focal point in the back of the eye on the retina. From a distant source, the lens is actually going to be flatter, and it actually will get basically lengthened a little bit by these muscles that help flatten up the lens so you can see further away. So further away, the light rays that actually come in are more parallel. the rays that come in from when you're focusing more are actually going to be more bent. So what you're doing with your eyes when you're looking at something that's closer, you're actually moving them together medially more toward the midline of the eye source of where you're coming in. When the light rays come in and they get, refracted by the light, once it gets through the lens, the way that it's received on your retina is it actually flips it upside down and reverses the image. So it's kind of crazy. It reverses it from left to right or right to left and flips it upside down, and it's actually back here smaller than the actual object that you're seeing. The nerve itself, the optic nerve, will then have the bundle of axons that it's receiving the information. Remember that your optic nerve is a sensory only. So those signals are going to be coming in, and some of the fibers, those sensory fibers that come in, are actually going to cross over in a region that's called the optic chiasm and go to the opposite side of the brain, towards the back. You have some tracts that are actually going to be on the same side. So right eye coming in, it's going to go to the same side, and it's going to meet up with the thalamus and then connect that second tract that will then go posteriorly to the visual cortex in the back of the eye. And so what we have is we have our focal point here. So this is primarily what you're seeing. And then with your right eye, you can obviously see things out to the side on the right. And then with the left eye, you're actually seeing things off to the left. So here we're looking down at the inferior portion of the brain. So here's your left hemisphere. This is your right hemisphere. And so what happens is the fibers that are going to cross over through the optic chiasm, which is right here, are going to come in and then go to the opposite side. You'll have some that are going to synapse here on the thalamus, and then you'll have others that will then continue and then move on back and synapse in the back in the occipital lobe. And then same thing with some of the ones that go here. And then you'll have the lateral fibers that are going to come in and then synapse at the thalamus and then continue to the posterior portion. So that's how you end up seeing. Binocular vision is what gives you more of that depth perception. So this is a unique thing that humans and obviously chimps have, monkeys have. And this helps us be able to see the three-dimensional vision, and it's very important, obviously, at judging distance. So it's really critical. When somebody actually loses vision in one eye, it makes it very hard to actually have more of that depth perception, and it makes it more difficult to be able to drive. The word emmetropia means normal vision, and that means that they're 20/20. When somebody has myopia, that usually means that they're nearsighted, and then hyperopia would be that now they are farsighted. So hyperopia, farsighted, the eyeball is too short. When you have myopia, nearsighted, the eyeball is too long. And then what's called astigmatism, this means that actually on the actual unequal curvatures of the cornea or the lens are actually causing some blurring that occurs from the light. And so you're not able to focus on the points because they look like little lines. And so the retina has a difficult time adjusting for this. So when you look at an eye that is normal, all right, this would be a normal emmetropic eye that can just, focus normally, can see well, the whole bit is everything's good. The focal plane is exactly in that focal point right by that fovea portion of the eyeball at the back where the retina is. The myopic eye, the eyeball is too long. And so now what we have is that the focal point, instead of being, right here where the retina is, it actually happens anterior. It happens too early, and it doesn't focus in the backside here. So then what ends up happening is you end up needing corrective lenses, and concave lenses are actually going to help with that. When you have a hyperopic eye, which means now you're farsighted, now what happens is the eyeball is too short, and the focus point, or the focal point, is actually behind the eyeball. So now what we end up doing is we have to correct that by having a convex lens that then helps bring the focal image back forward and then ends up where you want it on the retina. So that is how they're able to do the actual corrections when you get glasses. Then the reflexes that we have with our eye, convergence means that your eyes are going to move medially when you're trying to focus closely on an object. The photopupillary reflex, this is what's going to cause the pupil to constrict when bright light is shown on it. So for example, when you're testing to see if somebody's pupils are reactive, what you do is you shine your little pen light in there, and if the pupil constricts, that means that we have reactivity. If it doesn't respond, then we know that there very likely is some kind of injury, or that somebody is actually has some kind of opiate intoxication going on. The accommodation portion of the pupillary reflex, what happens here is that part of what's going to occur is that viewing these close objects actually allows for that pupil to constrict a little bit more so that you don't have light actually disrupting what it is that you're trying to see. Then in terms of what our vision does with sympathetic and parasympathetic response, I talked about this a little bit when I was discussing the two branches back in the nervous system. And we have little muscles in here that are going to function off the oculomotor cranial nerve with the parasympathetic response. And what it does is that it actually causes that pupil to constrict. So these muscles are going to cause constriction of the pupil. Then with the sympathetic response, remember now what is going to happen is you're going to have dilation of the pupil. So you're basically inhibiting the parasympathetic response when you go into a sympathetic state. So when we look at drugs, a parasympathetic type drug like an opiate is what's going to cause major constriction, right? Severe constriction of that pupil. So that's how you can tell, right? Are they on opiates? You have pinprick pupils. But when you have a drug that is a sympathetic like drug like crystal meth, you're going to have major dilation of those pupils, or cocaine, right? That's going to give you a big eyeball, right? You've noticed this with cats, for example. They're great at giving this example in terms of what happens. So that's what occurs with sympathetic and parasympathetic responses. Then our ears, this is where our hearing and our balance is housed. And again, hearing is controlled by the cochlear nerve. Equilibrium is the vestibular nerve. We put them together, and that's cranial nerve number 8. The vestibulocochlear. And we have within these things that are called mechanoreceptors. So these are going to be little receptors that are actually going to help you in terms of balance and helping with proprioception of what's taking place in the ear. So we have our ear, we have an outer ear, an inner ear, or a middle ear, and then the inner ear over here. So the outer ear, for example, is just the outermost portion that includes the pinna, which is the membrane that makes up your outer ear, and this is all elastic cartilage. And then we have the opening, and as it comes in, the opening that it's entering into the actual temporal bone of the skull is called the external acoustic meatus. And any type of plug or anything that gets in the way here is going to obviously impact what happens on the inside. So the sound waves, what they do is they come in through this canal, and then they're going to hit the tympanic membrane, and that is going to cause vibration. So the middle ear has the tympanic membrane, which is your eardrum, and then 3 bones, the malleus, the incus, and the stapes. And these are also known as the auditory ossicles, and which means that they are the little auditory bones. And so when that comes in, it causes vibration of these bones, and then the vibration continues the waves in to the inner ear. So your middle ear it starts at your tympanic membrane. This right here is the malleus, which then hits the anvil and then will hit the stapes. And then the stapes will send the vibration of the wave into this window. And this vestibule, basically the round window area, this is where the waves are going to come in for the sound. If it's sound that's coming in, what is going to occur is that now you're going to have those sound waves continue into what's called the cochlear side, and then opposite that are the semicircular canals, which is where the equilibrium is located. So middle ear is tympanic membrane, the malleus, the anvil, and then, the incus, and then the stapes. Then the inner ear is where your hearing and balance actually takes place. This is where you're going to have the receptive cells that are going to help you to be able to listen and then be able to balance. So we're going to have a bony labyrinth, and then within that, you're going to have the cochlea on the right, which is the one that looks like a little snail's shell. And then on the other side, you're going to have the semicircular canals, and then the vestibule is this area where the round window is located. So the vestibular apparatus, the way that works, is that you're going to be having information coming in from proprioceptors from the external portion of your body to help you figure out where am I in terms of the space. And so that signaling mechanism is coming in through the spinal cord based on what is happening with your head position. And then what your head is doing, if it's still or if it's in motion, it's going to trigger different portions of these semicircular canals to determine what is going on. So the maculae within the semicircular canals are going to inform your brain about static equilibrium, so when your head is still. And the crista ampullaris is what's going to inform your brain on rotational and dynamic type of movement. So this is what we look at. So here's the hearing portion, the cochlea. What we're focusing on with where you're moving and the actual balance in your equilibrium is what occurs within these semicircular canals. So the macula report the head position, and then that info is going to get transferred to the vestibular portion of the vestibulocochlear nerve. Within the macula, what you have are little teeny tiny receptor cells that are little hair cells, and you have little crystals just above that are floating in a gelatinous type membrane, and they roll within this membrane. The rolling of these little things that are called otoliths, these little crystals, are going to trigger the hair cells to receive the information and bend. So what occurs is you have these things, these crystals that are the otoliths. They are embedded in this kind of gelatinous type fluid. And then below that, you have these little guys that are called stereocilia. These are little hairs. And connected to those, you have these little kind of columns that are called kinocilium. And so collectively, these are the little hair receptors that then go down into the actual connections of the vestibular nerve endings that will then feed into the actual vestibular nerve. And so this up here is what moves within the gel to send the signal to the little hairs that then will tell the nerve what your body is doing in terms of your static head position. So when your head is upright, you are neutral, right? Nothing has moved here. Now, when we move our head forward, what is going to occur is that these little otoliths are actually going to move. When they move, they're going to cause movement in that gel, and so that fluid is going to cause the little hair cells underneath to actually move. And so what happens is that you have impulses generated. So you're going to have depolarization and action potentials occur. So when the little hairs are bending toward the kinocilium, so this little kinocilium crystal here that is connected to the little stereocilia, the little otoliths bend this way. That causes the hairs here, the little kinocilium, is going to actually move towards where that hair is located. So now that excites the nerve and says, hey, my head is moving in this direction. Then when you want to go the opposite side, now what we do is we want to hyperpolarize the ones that move forward, and then you're going to activate the ones that move backward. And so you're constantly turning on and turning off based on what your head position is and triggering the signal mechanism here. And it all has to do with what is that kinocilium doing based on the positioning of where it is with the hairs, and then which parts of the actual vestibular sensory receptors are being activated. The crista ampullaris, this is going to be the angular or rotational type movements. And so now what's going to happen is that you're going to have fluid moving opposite the direction of what the head or the body is actually doing. So you have this stuff called endolymph, so it's located within that region. And then the crista ampullaris, they actually look like little dumbbells embedded in the semicircular canals. And so what happens, and you'll notice that these little semicircular canals kind of look like a roller coaster. And they're positioned based on the plane of movement that is taking place. So where is your head? Is it upright? Is it laying flat? Is it at an angle? Are you upside down? What are you doing? And so these crista ampullarises are going to respond based on what is taking place with your head position as you're moving. The static equilibrium, the macula, are located in a different spot, and they're the ones that are going to then inform what position is my head in. So when your body is moving, this is where you have your crista ampullaris. When your head is going to be in its position, whether it's bending forward, bending back to the side, or it's static in the zero position, that's going to be the macula. So when we zoom in, let's look at what happens. So here, this skater, right, this is the left leg, this is going to be the right leg. So when we are spinning, right, in this direction, what is happening is the body is moving opposite the flow of the endolymph. And so that's how it knows which direction you're moving in, and you don't fall down. Now, when we want to change directions, obviously we have to slow down and change and then go the other way. So during your acceleration phase, when you're rotating, all right, so think about a gymnast or like Simone Biles, for example, when she's doing all those crazy, twists and turns and flips. what is happening is she's able to do that and maintain her awareness in the space above, the balance beam or on the tumbling that she's doing based on what this directional system is informing her. So you're accelerating and the flow of the endolymph is moving in the direction opposite the rotation of the actual body. So now we're exciting those hair cells. Now we want to change, we want to go the other way, we're going to slow things down. So now in order to decrease or basically hyperpolarize the cells, now we're going to inhibit them. So what that does is now the endolymph actually flows in the direction that the body is moving in. And so then that causes the change. And then when the body starts to accelerate again in the opposite direction, now the endolymph will again move opposite where the body is actually rotating. So when Simone Biles got the twisties, I think you guys probably all read about this during the Olympics, she was not able to determine where her body was in the space and moving so that she could land on her feet. And so that obviously becomes very dangerous because if you can't tell where you are in space and what your head is doing, you're not going to know your head from your feet. And then obviously you could suffer a pretty significant head injury and cervical injury if she fell directly on her head. So that's what that was referring to. Then in terms of our hearing, we have the organ of Corti. And so what this is that kind of snail-like looking region. And on there, again, we're going to have receptors. And we have this thing, it's kind of a tube that is called the cochlear duct. And within that, we have membranes that are directly connected to the cells that are then going to basically vibrate the membrane and tell your hearing, right? So you're able to tell, okay, what are these tones of what it is that's coming in. So when the sound comes in, they're going to come into the round window here, and then that sound is going to enter into the organ of Corti. So let's zoom in and look at that a little bit more closely. So as the sound comes in, you're going to have what is called the basilar membrane, which is this little thing right here. And then you have the membrane here, which is the tectorial membrane, and then that is connected directly to these little hair cells. So when we zoom in, what's going to happen is the actual basal membrane, the basilar membrane, which is kind of the base, is going to vibrate. That then triggers the tectorial membrane to move and vibrate as well based on what is happening with the actual sound. So our sound comes in, hits the eardrum, which is the tympanic membrane, that causes the hammer and then the incus, and then the stapes to vibrate, and then the sound comes in, so that's amplified, and then it triggers those action potentials. So it comes in, this is where that basilar membrane is located. This basilar membrane moves, that then causes the tectorial membrane to also vibrate, and then that sends the signals to these little teeny tiny hairs, which are part of the receptors in the organ of Corti, that then send the signal directly to the actual cochlear nerve, and then that will travel to that portion in the temporal lobe for you to be able to hear what is going on. And so when damage occurs from very significant loud noises or loud basses, very strong basses, what is ending up happening is that this membrane vibrates too much, but then causes the tectorial membrane to vibrate too much, and then eventually these little hairs will actually get damaged. So think of this as, basically a tsunami coming in and just like squishing something when you have a very significant high sound. So a gun goes off, a cannon goes off, there's some kind of explosion, something happens that is going to cause significant damage to the connection here. The sound when it comes in, so this is just to give you an idea of what is going through. This is a pinnae, which is your outer ear. It comes in through the canal, hits the tympanic membrane, passes through the auditory ossicles, enters the oval window. And so what occurs is that these little auditory ossicles, in their vibration based on how much hits that tympanic membrane, they amplify the sound that comes in through the oval window. And then what is going to occur is now, as we enter into the inner ear and the cochlea, now we have the sound going through, and you're going to be able to hear what is taking place. So how we hear has to do with how much vibration is coming in to the actual organ. So in the innermost port, or the portion proximal to where the sound waves come in, this piece here, here's your round window, this is where we have the portion that is going to receive very high notes. So the hertz, that's how we measure frequency of sound, the hertz that are coming in, very high notes, strong basses, these are going to be at the very beginning. All right, so this is why the damage from very, very high-pitched notes or very, very strong basses can actually damage here, because this is where you're going to have the largest space in terms of that sound to be able to come in. Then as you move your way in, now you're getting into a smaller piece of the tubing or the tunnel that is coming through, and now the hertz are going to decrease in frequency. So here's where you're going to hear much lower type notes. On the entrance is where you're going to hear the much higher type notes. And so high-pitched sounds, those are going to be more basilar membranes, disturbed short little fibers. And then the very low-pitched sounds are going to be more the floppy fibers more towards the end. So high-pitched at the beginning, low-pitched further towards the end. When you have what's called deafness, there's going to be two types basically. Conduction, which has to do with the tubing. So how is the sound passing through the external canal and the middle ear? So if there's an issue, if there's buildup of wax, or you have an infection that is now causing an inflammation within the external ear canal, or you're wearing earplugs, all right? You're purposely then causing conduction deafness. But you're actually doing it to protect the vibration of the sound that's going to be coming in and hearing and hitting that tympanic membrane. When you have what's called sensory neural deafness, now we're talking about actual nerve damage and what is going to happen to those sensory receptors within the hair cells that then carry over into the actual neuron. So now we have structural damage that is taking place. So one of the things that can happen, anything that's going to hinder that vibration transmission. So for example, if you have ossification of the little bones of the ossicles, that would eventually end up damaging the ability to hear, because then the vibration isn't going to be as clear and the amplification of sound is not going to be able to take place. Now if you have damage within the actual hair cells, now we have a problem, because now the receptors for hearing, right, in the cochlear side, you're not going to be able to hear very well. And then there's a condition called Meniere's syndrome, which what it does is it actually affects the inner ear, and it will be often displayed and be a comorbidity with an individual who has hypertension. But then what happens with it is the person will have difficulty hearing, so deafness, hypertension, and vertigo, so dizziness. And we're talking debilitating dizziness, where the person will probably be very, very nauseous and be unable to even stand up, and it could go on for weeks. So Meniere's syndrome is no joke. It can be very, very debilitating. Then in terms of our chemoreceptors, the chemoreceptors are located in our olfactory region. So basically what we have is receptor cells that are then going to be transmitting the signal through little olfactory hairs that are in our nasal passages. And what you're receiving here is the actual chemical structure of what you're smelling. And then that goes in to the olfactory nerve within the temporal lobe. And then that's transmitted to the olfactory cortex, which is where your sense of smell is actually located. And then what happens there is then you form a memory, which is because of where it's located. It's a region that has a very, very strong memory center. And this is why certain smells can trigger a lot of either traumatic events, or it can trigger pleasant events, right? That you remember of things that when you were little, maybe regarding cookies that were being baked at grandma's house, or if you've been around, obviously those of you who are around a lot of fire, or if you've been around dead bodies, you will never forget that smell. And that's part of why, is because of the impact that this olfactory region has in our memory. So what we have here is, this is the mucosal membranes that are within our nasopharynx. And then what you're seeing here is these are the olfactory fibers that come in and come off the sensory cells in the olfactory region, and then the olfactory bulbs that are within that temporal lobe, and then we'll transfer it into the actual cortex of the olfactory cortex of the brain. Then taste buds, so your sense of taste, these are located on your tongue, and you also have a little bit over in the upper portion of your pharynx, so towards the back of the throat. And on our tongue, we actually have what are called papillae. And the papillae actually help provide that transmission of the taste, but they can also become inflamed. So you can have little canker sores that develop from, immune suppression that might be taking place if you're sick. And then we also have in the very back of the tongue tonsils, but these are not part of your taste buds. So what the taste buds do is that they allow us to have the sensation of either something being sweet, sour, acidic, right, alkalinic, or basically a real yummy taste. Or if you have an alkalinity, it's going to be more bitter. And so what we have on our tongue are actual little things called gustatory hairs. And what they are little receptors for the gustatory cells that are embedded within the tongue in the region where the taste buds are located. And then as that chemical comes into these little kind of openings that are in our tongue, what it does is that it receives the information on the little taste buds and the receptor cells, which are connected to the actual nerves of the cranial nerves that are going to taste. So you're going to have tasting that is going to occur through the facial nerve, the glossopharyngeal nerve, and then the trigeminal nerve in some cases, and then go to the gustatory cortex that is located within the insula in our insula lobe that's in our brain. So our 5 basic taste buds are going to be sweet, sour, bitter, salty, and then what we call umami, which is what I always call oh yummy because it's a nice beefy taste. And so sugars are going to have a very distinct shape to its molecule. So the taste buds that are dedicated to sugar will see that in terms of that structure of that alcohol that is on a sugar molecule. Then sour is going to have more of the hydrogen ions, which is going to be more acidic. Alkaloids are going to have more hydroxyl, are going to be more bitter type tasting. And then salty are going to be more metal ions, more of your calcium, your sodium, those types of salts. And then again, umami. Then in terms of the developmental aspects of the special senses, so obviously they start being formed very early on in the embryonic development. And this occurs, the nervous system actually develops very, very early because this is the thing that's going to direct everything else. So if there's any kind of maternal infection that occurs because of an issue with the mom, right? She gets a meningitis or she gets some kind of really severe bacterial infection. This could actually cause a problem in terms of visual abnormalities or auditory abnormalities in the fetus. And so this is how you can end up with a child being born that is not able to see or not able to hear. Vision itself obviously is going to require the most learning. So when babies are first born, they don't have sharp vision. They can't see perfectly. That's why they sometimes have that kind of like little far away look. But they are, basically they just have what kind of looks like stuff in front of them. So their sense of smell is going to be huge in terms of being able to identify their caregivers. And, very early on, they start, receiving that information about what feels good or what feels bad. And then the eyes themselves will continue to grow and mature until about age 8 or 9. So this is why vision in a child is very, very important, because if they have a problem with that, it's important to get that corrected as soon as possible. And usually where that is going to be identified is going to be, usually when they start school, or if you're pointing things out, in the car and look like, oh, look at this, look at that, and they're like, I can't see it. That's something to really pay attention to. Then as you get older, you can have what's called presbyopia. And presbyopia just means that your eyes are not adjusting to distance or to nearsightedness very well. And so the lens itself, its elasticity starts to decrease, and it makes it harder to be able to focus on close vision. So you'll notice that you'll tend to hold things further away so that you can actually read it and so that it can be into focus. So that's how you start knowing that, hey, I'm having a little trouble with seeing things up close. Lacrimal glands actually decrease in activity, so you produce less tears, and this is why dry eye is a common thing that you'll see with older adults. And eventually some of the pigmentation of the actual iris starts to go away, and in some cases you can actually start having cloudiness that occurs when you have tissue buildup, and then that will cause cataracts. Then the dilator muscles of the iris also start to change, and it makes it more difficult to be able to actually do that focusing that you need in order to be able to see things up close. So newborns, in terms of their hearing, they can hear sounds, but initially everything that a newborn does is going to be very reflexive in nature. And then by the toddler stage, hopefully by then you have been able to determine, is there an auditory issue with the child or not? Because this is where obviously they're going to be hearing sounds, developing patterns, putting patterns in, so recording patterns into their brain and creating memories of what words are and what they sound like, and then be able to repeat them back and start talking. So that's really important. This word called presbycusis is a type of sensory neural deafness that occurs from a result of the otosclerosis that happens within the auditory ossicles. And then that in turn could then cause problems, obviously, because now if the signal is not coming in, those cells are not going to be as active and they're going to diminish in their sensitivity within the inner ear. then if there's any kind of congenital problems that occur from, say, malformation of the outer ear in the pinna, or something is going on where the opening for the sound coming in is missing, or it's closed up, it never opened or it never formed, obviously that's going to be an issue that is a congenital defect that may or may not be able to be corrected. And then our taste and smell, obviously it's going to be most acute at birth. And then as the child develops and grows, it will continue to develop, things for what they like and don't like. And then as you start to age, just like everything else, sensitivity will decrease. And then sense of smell actually does start to decrease somewhat, which then ties in directly to your ability to actually taste. So that's the end. Nice short chapter with the special senses. And then we will be moving on into the endocrine system. Again, reach out if you have any questions, and I'll be happy to help you out.